many years, Ann McMillan has been an advocate for our community through her dedication in a wide variety of activities. She is always generous with her donations of time and energy and has been active on numerous community and civic boards, including Children's of Alabama, the Birmingham area chapter of the American Red Cross, both of which she served as board chair, and the Women's Fund. As Vice President for Community Affairs at South Trust Wachovia, she managed charitable contributions until her retirement, and now she continues that tradition with leadership positions in such community organizations as Leadership Birmingham, Leadership Alabama, as well as the UAB Leadership Cabinet. But it goes without saying that her most exciting, unusual, and eclectic community service is a member of the Broad Street Committee, which is the school's advisory board. Ann has received many awards from, among others, the Junior League of Birmingham, the Metropolitan YMCA, the Girl Scouts of Cabo Council, and the Southern Women's Committee of 50 in recognition of her commitment to volunteerism and service. Ann is here today with her husband, former Alabama Lieutenant Governor George McMillan. Please join me in welcoming Ann and her family and thanking her for all of her contributions to our community. So before introducing our speaker today, I want to thank Dr. Martha Wingate and Julie McDonald for again organizing and planning today's event. They have both worked tirelessly with Ann and other stakeholders interested in family and child health to identify and invite our speaker, as well as to continue the work on ways to maintain the energy and momentum that comes from this annual lecture. Martha and Julie, where are you? Thank you. So now it's my honor and pleasure to introduce Dr. James Jimmy Collins, who's professor of pediatrics and neonatology at the Ann and Robert Lurie Children's Hospital in Chicago, who will deliver this year's Ann Dow McMillan Lecture in Family and Child Health. Dr. Collins received his MD and MPH from the University of Michigan. His interests include perinatal epidemiology and women's reproductive health. His research focuses on understanding the social determinants of racial and ethnic group disparities in birth outcomes, preterm delivery, low birth weight, and neonatal and post-neonatal mortality in the United States. As you can imagine, he is widely published and serves on many nationally prominent committees and organizations. Dr. Collins is also a recipient of numerous awards, including the Dwayne Alexander Award for Academic Leadership in Perinatal Medicine from the National Institute of Child Health and Human Development, Outstanding Teacher of the Year from Northwestern University, and the March of Dimes Jonas Salk Health Leadership Award. Please join me in welcoming Dr. Jimmy Collins to UAB, to the UAB School of Public Health for the 2015 Ann Dow McMillan Lecture in Family and Child Health. Dr. Collins?
Before I kind of talk about the racial disparity, I just kind of want to set it up by kind of talking about the general epidemiology of infant mortality in this country. As some of you probably know very well, infant mortality is defined as the number of infant deaths which occur in the first year of life. A high rate signifies unmet health needs. Unfortunately, there are three striking / disturbing characteristics of infant mortality in our country. One, we rank neither first, fifth, 15th, 20th, 25th, but we're down to 29th in the world in overall infant mortality. And unfortunately, our position has really deteriorated pretty consistently since the 1960s. We're going to spend a fair amount of time talking about the racial disparity, but I just want to point out the fact that if whites as a whole were a country, their infant mortality rate would only rank 26th in the world. So clearly this problem of infant mortality extends beyond the racial disparity. This slide looks at infant mortality rates by ethnicity in this group, and we see that African Americans have the highest rates, and we see that Asian Americans and Mexican Americans have very low rates. We really won't be talking too much about Mexican Americans, but they are very interesting because their overall rate's very low, despite them being very economically deprived. We're going to really talk about African Americans and non-Latino whites. The vast majority of African American and white infant deaths occur in the first 28 days of life, and that is defined as neonatal mortality rates. And this slide looks at neonatal mortality rates for infants born in this country since 1950. And you can see there's been a dramatic improvement since the early 1960s. 90% of this improvement in overall neonatal mortality has been due to really neonatal medicine's ability to take care of small, premature infants. This slide looks at two components of overall neonatal mortality. One is birth weight specific mortality, the other is birth weight distribution. As I hinted, we do a fabulous job of taking care of small preterm infants. If you're going to weigh 900 grams, unfortunately, there's no better place to be born in the United States. But unfortunately, a group of infants who weigh 900 grams will never do as well as a group of infants who weigh 3.5 kilograms. And we see that low birth weight is a far more powerful predictor. Low birth weight infants account for just under 8% of births, yet they account for 2/3 of the deaths in this country. And 2/3 of these infants are born prematurely at less than 37 weeks. Only about 40,000 infants a year are born with a birth weight less than 1,500 grams, and they account for just over 1.5% of births, yet they account for 50% of the deaths. Essentially, all of these infants are preterm. There's things beyond just the mortality. There's also long-term problems with being born small. Approximately 16% of very low birth weight infants are moderately or severely handicapped if they survived. Neonatology is a lot of things. Unfortunately, inexpensive is not one of them. There's also the ethical dilemma. We take care of a lot of small babies who maybe a long time ago would have expired on day one. Now with our technology, they're living to maybe 2 months of age, 3 months of age, but ethically, are we doing the right thing for the pain that we put these families through, the suffering that's caused for these little tiny babies? For those babies to survive the first year of life and grow up, now we're now starting to realize that there are long-term health consequences if you're born small. You have increased risk of coronary artery disease, hypertension, type 2 diabetes, metabolic syndrome, osteoporosis, and some people are starting to look at cancer risk. All this is from being born small. And this slide looks at a 7-decade trend of low birth weight rates in this country for both African Americans and whites. If we were to look at other countries, we would see low birth weight rates slowly declining. We see that for African Americans, they've been flat. We see that for whites, they've been flat. Half the deaths occur among those with a birth weight less than 1,500 grams, and we see that for African Americans, things have been slowly inching their way up. For whites, they've been relatively flat. Recently, they've started to inch their way up. This has really been due to the increased risk of being born early if you're conceived with assisted reproductive technology. We spend a lot of time in public health talking about the importance of the association between age and pregnancy outcome. And from all social reasons, having an infant as a teenager, there's nothing good about it. And we see that for whites, it's also nothing good about it with respect to low birth weight rates. Low birth weight rates are at their highest among teens, then slowly decline as women enter optimal childbearing age. But for African Americans, rates are actually lowest among teens and then slowly increase with age. This has been called a weathering phenomenon. We'll talk more about this later. If we look at preterm birth rates, very similar for whites. If you're a teenager, preterm birth rates are at their highest, and they slowly come down as women enter their 30s. We don't see the same trend among African Americans. They tend to hover between 16 and 18% independent of age. This slide looks at low birth rate rates by maternal education and race. The x-axis is maternal education in years. The y-axis is percent low birth weight. African Americans are in blue, whites are in red. And we see that for both groups, as you might expect, as education level increases, incidence of low birth weight infants decline. If you look to your far right, among those with 16 or more years education, we still see the disparity persist. It's actually widest among college graduated women. And we see that for African American women who graduate college, their low birth rate actually exceeds that for whites who didn't complete high school. So clearly socioeconomic status is important, but it's not explaining the disparity by itself. In the late 80s and early 90s, there was a lot of information looking at the role of prenatal care, thinking that prenatal care could be the bullet. If we gave everyone adequate care, we could eliminate the disparity. This study was done looking at women who were born in California and comparing it to the cohorts also born in California who were also in the military. In the military, everyone gets the same amount of prenatal care because it's the military, and everyone gets the same prenatal care that's kind of scripted. So it's the same level of care, and you have the same access to care. And we see that the racial disparity is the same in the civilian population as it is in the military. Another indirect of looking at the role of prenatal care is looking at the racial disparity among women who conceive with assisted reproductive technology. Clearly, by definition, these women want to have babies. I'm a neonatologist. I take care of a lot of babies who are born prematurely. These parents will do anything they can to have a baby. So if you tell them to do bed rest, they'll do bed rest. If you tell them not to smoke, they won't smoke. They'll do whatever you say. And clearly they have access to the highest medical care available because they did conceive of assisted reproductive technology. So, but we still see a racial disparity with respect to whites who are in red, African Americans in blue, with respect to term low birth weight, preterm low birth weight, and very low birth weight. So to try to sort of get at this a little bit, we thought, let's see what relationship we can see among the majority population. So this is a study looking among upper-class white women who experienced, unfortunately, downward economic mobility from the time that they were conceived to the time that they had their children. And we see that for those who experienced no downward mobility, they had an overall infant mortality rate of about 5.1 per thousand. For those who experienced moderate to extreme mortality, rates went up to 14 per thousand, essentially equivalent to the African American population. We talked about how preterm birth is very well associated with infant mortality. We see that among whites who experienced no downward economic mobility, their preterm birth weight was 5.4%, very low. But as downward economic mobility improved or went down from slight to moderate to extreme, preterm birth rate rose from 5.4% to 6.5 to 8.5 to 10.1. But we see only a small handful had a lifelong impoverishment, and we see that their preterm birth rate was 17%, essentially parallel to that of the African American population. So we spent a time talking about preterm infants and low birth weight infants. This is an interesting way of looking at this. A third of the deaths occur among infants who are term. So this slide looks at term infant mortality rates by maternal nativity. Nativity being the country where you were born. And we see that for whites, if you're born in this country and born at term, those infants had a higher mortality compared to whites whose moms were born in Europe. The exact same phenomena happened among African Americans, and the exact same phenomena, though shrunken a little bit, occurred among Mexican Americans. We look at term infant mortality rate, maternal education, and nativity. We see again the x-axis is maternal education in years. As education improves, number of deaths per 1,000 live births go down, but we still see among those who attended some level of college, there's still a disparity among whites who are U.S. born versus whites who are foreign born, suggesting there's something about being born here which isn't good for outcome among infants who are born at term. That little 5-10 minutes we've spoken about sets the stage for really what I think gets at the heart of this issue with respect to preterm delivery, namely transgenerational factors, which are defined as those factors, conditions, environments experienced by one generation that impact the pregnancy outcome of the subsequent generation. A picture is worth 1,000 words. Basically, how is this little girl's birth weight when she was born related to her maternal grandmother's experiences? Unfortunately for African Americans, the ultimate transgenerational experience relates to slavery. So we wondered, is it something about the experience of slavery descendants that is bad for pregnancy outcome, or is it something about the slaves themselves which predispose to having a preterm low birth weight infant? Is there a genetic component? So we thought, well, let's look at this by looking at women who themselves were born in Africa who happen to come here now to have their children. Since approximately 65% of African American genes are from African origin, we would think that if there's an African component to this, we'd expect that their rate of poor outcome would be very similar to the African American population or even worse than the African American population. Fortunately, in Illinois, over a 15-year period, we were able to collect data on 3,000 moms who themselves were born in Africa who delivered in the state of Illinois. We went back, and these moms, 80% of them were actually born in the countries which originally slave trade was very profitable from. So it gives us a contemporary population to compare to. And we compare those to U.S.-born whites and U.S.-born blacks. And since I'm an epidemiologist, I have to have one bell-shaped curve in here. And this is a bell-shaped curve. African Americans are U.S.-born blacks are the dotted group, and we see that their birth weight is shifted downward by about 300 grams, significantly less than the other two. But the group that we're most interested in are those who are themselves born in Africa, and we see that their bell-shaped curve kind of overlaps that with the general white population. Well, bell curves are good for what they are, but they're terrible because the real meat of the action is in the tail. And we really want to know what's happening in the tail because that's where the mortality occurs. And we see that among looking at low birth weight, defined as less than 2,500 grams, we knew that U.S.-born blacks would have a high rate, just over 12%. But African-born blacks had a rate that was actually less than that, about half of that, about 6%, very similar to U.S.-born whites. This is inconsistent with the genetic process, but suggesting that there's something about U.S.-born blacks which is very different than African-born blacks. Look at very low birth weights, less than 1,500 grams. We see the very similar phenomena. U.S.-born blacks had a low birth rate of about 1.3%, compared to 0.4% for African-born blacks and about 0.3% for U.S.-born whites. We control for the things that we can control for, namely age, education, and marital status, and those still these consistent results that we see here. So clearly U.S.-born blacks are very different than African-born blacks. This doesn't seem to be due to a genetic process. One of the things that the people who didn't believe the results thought that maybe this is related to a selection bias. People who come from Africa today, they tend to be wealthier than people who stay in Africa, and maybe they're healthier than people that stay in Africa, so maybe there's a selection bias that we're really comparing apples and oranges. So we thought, well, maybe we can get around this by looking at women who were born in the Caribbean. Caribbean women tend not to come as far, you have to come as far as we do from Africa, and they also tend not to be as economically affluent as African-born women. And we see a very similar phenomena, namely Caribbean-born women doing very similar to U.S.-born U.S.-born whites, dramatically worse than U.S.-born blacks. But still, it begs the question that maybe there's also a selection bias going on here also. So it led to the thing here, is this a genetic code versus a zip code? And there are two leading theories. One is the genetic code theory, namely black women who migrate to the United States are intrinsically healthier and have better birth outcomes than those who do not migrate. Next is the zip code theory, namely lifelong residence in this country, or at least something closely related to it, is detrimental to the birth outcome of African American women. So let's get a feeling for, is there a genetic component to preterm delivery to begin with? Our country is not very good when it comes to having big data record sets, but some of the Scandinavian countries are. There's one study published from Denmark, which looked at women who had looked over 1 million births. Women who had a history of preterm birth had about a 6-fold greater risk of having a preterm infant. Women who had a history of preterm birth but changed partners still had about a 4-fold greater risk of having a preterm birth. So at least it takes maybe dads out of the equation, but there still could be a genetic component with respect to mom's genetic makeup. A Swedish study found that sisters of women who had a preterm birth had about a 2-fold greater odds of having a preterm infant themselves. So maybe there's something there, but sisters have a similar genetic makeup. They also tend to have the same environmental makeup also, so it's hard to tease that out. We looked at our transgenerational data set in Illinois and found that moms who were born prematurely, less than 37 weeks in blue, compared to moms who were born at term in red, we see that for whites, they had a slightly greater risk of having a preterm infant themselves. And among African Americans, that risk was even less. We did some fancy modeling and control for the things that we control for, and essentially the difference went away completely. So if there is a genetic component, it seems to be very small. In terms of the genetic code theory, there was another study which was published looking at U.S. blacks who were born in one state and then moved to another state to have their baby, looking at a selection bias within the United States movement, and it found that moms who were born in one state and moved indeed had a better outcome. And they hypothesized that their data supported a healthy migrant theory. But if you think about it, if you move from one place to another place, you tend not to move from one place unless it's a better lifestyle, which is maybe a better economic lifestyle. They didn't take neighborhood income into account. So we decided to do a study looking at what we know best, namely Chicago, to determine the association between migration from Chicago to the suburbs and its associating with preterm birth rate rates among African Americans and whites. And this is a natural experiment which occurred in the 1970s to early 1990s, namely white flight from Chicago. And this kind of gives you an idea. It's kind of a fake out. My daughter made this slide when she was just last year. She's 12. And it makes it seem Chicago seems like it's small. Chicago takes up 90% of Cook County. But I could not take it out, you know. So Chicago takes up most of Cook County. Then there's Cook. Then there's the collar counties, which are Lake, McHenry, Kane, DuPage, and Will. And we see for whites, 30% were born in Chicago, stayed in Chicago. About 41% made it to suburban Cook. 29% made it to one of those 5 collar counties. For African Americans, 88% were born in Chicago, stayed in Chicago. About 10% made it to one of the collar counties, made it to suburban Cook County, and only 2% made it to the collar counties. So let's see what effect this has with respect to preterm birth. We see that for white mothers, born in Chicago, preterm birth rate of about 5.1%. For those made it to suburban Cook, 4.2%. Those made it to the collar counties, 3.5%, which is incredibly low. We see a similar phenomenon occurred among African Americans, but not as stark. But it does give some idea that actually maybe there is something going on here with a selection bias, with healthier people having improved outcomes. So we looked and see, well, what association does this have with risk factors? We found that white mothers who migrated, actually they had less risk factors. They were less likely to be teens. They were less likely to be uneducated, less likely to be unmarried, less likely to smoke cigarettes, less likely to receive inadequate prenatal care. And they were less likely to live in low-income neighborhoods. We see 21% for Chicago only, down to less than 1% for the other 2 neighborhoods. This looks at African American mothers who migrated, and they also had less risk factors. But the biggest risk factor is that neighborhood in the lowest quartile, which is less than $25,000 a year. We see those who stayed in Chicago, about 74% resided in those neighborhoods, compared to 16% for Cook and 4% for the collar counties. So for those of you who aren't in statistics, aren't in epidemiology, we control for all those things at the same time mathematically, and we found that there is no difference whatsoever for women who stayed in Chicago, who migrated to either suburban Cook County or to the collar counties, when you take neighborhood income into effect particularly. So it really kind of discredited the genetic code hypothesis. But we thought, as a little sidestep, still thinking about genetics, let's look at women who were born in Africa or were born in the Caribbean. They come here, they have babies. Those baby girls grow up here. Those baby girls get pregnant and have babies. Are their outcomes good like their mothers were, or do things get bad like African Americans who've been here for a while? So we actually designed a study and completed that doing that. And this is a slide that kind of tries to present that. Daughters are in blue, granddaughters are in red. We see that for whites who were born in the United States, their daughters had a moderate low birth weight of just under 6% compared to just about 4% for granddaughters. Not a big difference. For whites who were born in Europe, a very similar trend occurred. For African Americans who were born in the United States, rates were about 10%, went up to 12% for granddaughters. But the group that we're most concerned about are the African Caribbean group. We see that for those who were born in Africa or the Caribbean, their daughters had a moderate low birth weight of about just under 6%, but in one generation, their granddaughters had a rate of about 12%, very similar to the general African American population. So if there is a genetic advantage, it sure isn't transcended itself across one generation. And no gene mutates that quickly, so we think it's something about living here for a long period of time, which is detrimental to pregnancy outcome. Which leads us to testing the zip code theory, the effect of racism. Why discuss racism? To eliminate racial disparities in health, you need to examine fundamental causes. Race is only a rough proxy of socioeconomic status, culture, or genes. However, race precisely measures the social classification of people in our race-conscious society. We hypothesize that racism is a fundamental cause of racial disparities in health. There are 3 types of racism: institutional, personally mediated, and internalized. And for the rest of the talk, we'll try to take you through each of these. Institutionalized racism, different access to goods, services, and opportunities in society as defined by race. Examples are housing, education, employment, income, medical facilities, clean environment, information, resources. Explains the association between socioeconomic status and race. Sometimes telling a story is a little bit easier than telling facts. And since I'm an epidemiologist, I've given you a lot of studies, a lot of data, but sometimes telling a story is a better way of looking at things. This is a story that Kamara Jones published in American Journal of Public Health 14 years ago. It doesn't seem that long. And she's currently with the CDC. And it's really trying to get across how racism can impact health. Her story is a gardener's tale. And what we have here is, imagine two flower boxes. One flower box is in the back of the house by the garage, and that flower box has old soil that's never watered, not tended. There's another flower box in the front of the house that is fresh soil's put in, it's watered, they want to sell the house, they want it to look good. The gardener has 2 packets of seeds. He puts 1 seeds in the back, they happen to be pink. He puts another set of seeds in the front, they happen to be red. And we see that the ones that's watered well, gets fresh soil, those more seeds actually germinate, 6 of them, compared to only 3 of the pink ones. Also, the pink ones are half as tall. So there's an initial historical insult. In this case, bad soil. There's also separation barriers. The fact that these flower paths, one's in the front of the house, one's by the garage. There's inaction in the face of need, because clearly the pink flowers need more soil, but they didn't get it. But it's supported by societal norms because the red flowers are in the front of the house, and we just kind of psychologically start to like red flowers. And the gardener makes the mistake. He just happened to pick 1 seed versus another seed, and he thinks actually the pink flowers aren't growing very well because they're just weak seeds to begin with. More than that, the red flowers kind of think that they're sitting pretty because there are a lot of us and we're tall. They kind of forget the fact that they kind of have an unearned privilege. Namely, they got fresh water and they got fresh sunlight. So now let's go back to data. Lifetime neighborhood experience in where I've been for the past 30 years. I still can't say home. Detroit's my home. White and black. What we did is we looked at white women and African American women in Chicago. And we looked at where you lived at the time you were born and where you lived when you had your baby. And we had 6 quadrants based on census tract income. And we see that lives are quite different for African Americans and whites. We see that for white women, 16% were born in the 4th quadrant. That's the highest quadrant. That's median family income in excess of $150,000 a year when they were born. And 16% of those women lived in the 3rd quadrant when they had their children. A whopping 15% were born in the 4th quartile. Things still were good. They still lived in the 4th quartile by the time they had their children. For African Americans, it's quite different. 0.6% of African Americans were born in the 4th quadrant when they were born and still lived there when they were adults. Dramatically different than whites. Other than the 1st quartile, if you're born in the lowest quartile and you still stayed there when you had your babies, almost 30% of African Americans, and only an abysmal 0.2% of whites. So clearly different lifetime experiences based on race and based on where you live. And this 6th grade pupil for one of the housing projects in Chicago wrote, and I quote, "For the last few days, whole lots of things have been going on, like shooting, killing, dying, death. That happens every day, like any week, any month. Like they tried to kill my cousin. My uncle almost tried to hurt my grandfather to take his money. Everywhere you go, you see people on streets and abandoned buildings, breaking in houses, getting stopped by police. Every day the same things happen." So this describes a stressful urban environment. You don't think you should have to do research, but we did, and needless to say, living in a place like this is associated with poor outcome. We see that for African Americans whose moms lived in low socioeconomic neighborhoods and the maternal grandmothers lived in low socioeconomic neighborhoods, that low birth rate is very high, almost 18%. Interesting, has it effect across the whole lifespan? No big surprise if we looking at lifelong environment, again, breaking it down by median family income. Those who live in low-income neighborhoods their whole life have an increased risk of having a low birth rate infant compared to living in a high-income neighborhood your whole life. Risk factors about the same for African Americans and whites. Risk factors are kind of a fake out sometimes, because it doesn't take into account the prevalence. The prevalence of poverty is so much greater among African Americans that from a public health perspective, it has a bigger impact. Mathematically, we can control for that or quantify that by doing something called a population attributable risk. And the students know this better than I do, but we can take into account the relative risk and the prevalence, and it gives us an idea if we could get rid of poverty, what impact would that have? And if we got rid of poverty for whites, because the prevalence is pretty low, even though the risk of poverty is the same, we'd get rid of 2.5% of low birth weight infants, about 1% of preterm infants, and just about 2% of growth retarded infants, or infants with a birth weight less than the 10th percentile for the gestational age. But for African Americans, if we got rid of poverty, we'd get rid of 20-some% of low birth weight infants, about 12% of preterm infants, and 20-some% of growth retarded infants. So from a public health perspective, if we could get rid of poverty, we'd have a major impact on reducing the number of pathologic birth outcomes for African Americans. Well, how is it that poverty impacts pregnancy outcome? We saw a slide initially looking at the age relationship to low birth weight among whites. And we see that young and advanced age are risk factors for low birth weight among whites. But for African Americans, things are lowest among teens and grow with time, and we call this weathering. So we designed this study to see what extent does neighborhood poverty do to modify the risk of low birth weight associated with advancing age among urban African American women. So we defined an ecologic risk factor using 4 things: median family income less than $15,000 a year, neighborhood with high unemployment rates, neighborhood with high homicide rates, and high lead poisoning rates. Neighborhoods with all 4 risk factors we empirically defined as extremely impoverished. Neighborhoods with 0 risk factors we defined as non-impoverished. So we think this is a good proxy for poverty. It's a bad proxy for affluency. This gives you an idea of the distribution. Approximately 20% of African American women were born in neighborhoods with 0 risk factors. 30% were born in neighborhoods with 1 risk factor, 10% with 2 risk factors, about 12 to 15% with 3 risk factors, 20% with 4 risk factors. In a perfect world, we want to do this same thing among whites, but we couldn't because 88% were born with 0 risk factors, 12% with 1 risk factors, none essentially with multiple risk factors. It says something in itself. So what we're going to do is compare the 0 group to the 4 group, non-impoverished versus the extremely impoverished. And this slide looks at maternal age in years. This time we go all the way up to the 40s, low birth weight rates on the y-axis again, non-impoverished in blue, extremely impoverished in red. And we see that the extremely impoverished group rates start to take off even as early as the late 20s and continues all the way through the 30s and to the 40s. We do see a weathering pattern among the non-impoverished group, but it's kind of like putting lighter fluid on a flame. Poverty just made whatever the it is causing this even worse. This looks at a risk difference, which just compares the difference for women in their early 30s to women in their early 20s. And we see that for non-impoverished, that risk difference was 4. For extremely impoverished, it was 8. What we'd expect it to be is essentially 0. But this just looks at where you lived at one point in time, at the time you gave birth. It could be that you've been there your whole life. It could be that something bad happened to you and you fell down into this. We don't know. So then this slide takes into account lifelong residential environment where you lived your entire life. We are very liberal with our definition. We decided that if you were in the lower group, that's a group just below the mean. If you're in the upper group, you're just a lower group, below the mean, upper group, above the mean. We see that for the lower group, we see weathering. Low birth weight rates went from 12.5% to 17%. But for those who live just above the mean, we actually see the same pattern among African Americans that we saw originally for whites. Rates were higher than whites, but at least we see the same pattern of rates being highest among teens and coming down as women enter their 20s and their 30s. Very reassuring. We look at SGA rates, growth retarded infants, we see that again. A weathering phenomenon is really those who are in the lower group. That means they were born in a low-income neighborhood and they lived in a low-income neighborhood when they delivered their babies, but low-income was liberally defined as less than the mean. We go from 11.1 to 14%. For the upper group, things come down from 10.9 to 6.9. We look at preterm birth. Among the lower group, things tend to fluctuate. They really didn't change. We get some hint of things coming down among the upper group. So these slides give us an idea that weathering really is driven by not only where you are at the time you have a baby, but where you've been your entire life course. And for those women who've been exposed to low-income neighborhoods their entire life, they see a weathering pattern. But let's look at women who experience upward mobility. We got to look at something positive. Let's look at women who were born between 1956 and 1976. They had their babies some 15 to 35 years later. 1956, 1976, approximately 48% lived in poor neighborhoods, defined as less than $25,000 a year. We see that for those who still lived in poor neighborhoods, 55%. Some had some upward mobility. They went from the first quartile to the second or third quartile, about 39%. Some had some real upward mobility. They went from the first quartile to the fourth quartile, less than, looks like 4%. And this slide looks at upward mobility among African Americans in Cook County. And we see those who experienced no upward mobility, namely they lived in low, impoverished neighborhoods their entire lives. Preterm birth rates hovered around 18%. Those that had some slight upward mobility, things came down a little bit. Those that had some modest upward mobility, things came down a little bit more. For that small group that had some real upward mobility, things came down pretty dramatically. But we see it still didn't approach those who had a lifelong residence in high-income neighborhoods. So it suggests that upward mobility does improve things, but doesn't improve if you've been there your entire life. But it also could be that with upward mobility, you're more likely to do things that make you have a healthy outcome, like similar to the migration study. So maybe it's that risk factors are improving. This isn't so much related to your neighborhood income per se. So we thought, well, let's look at it by risk factors. Let's look at it by education. Less than 12 in blue, and we see that for moms who are uneducated who still have upward mobility. I don't know how they did it, but they did it. We see that preterm birth rates come down. For those who are college educated, we see that preterm birth rate rates also come down with upward mobility. So it suggests that upward mobility by itself, independent of education at least, is associated with improved outcome. If we look at prenatal care, we know that women who have upward mobility are more likely to get good prenatal care. We see those who received inadequate prenatal care, preterm birth rates come down with upward mobility. For moms who received adequate prenatal care, life's even better, but you also see preterm birth rates come down. So clearly it kind of shows us that education is important, prenatal care is important, but economic upward mobility is defined by neighborhood income can also have an additional oomph for positive pregnancy outcome. So this is an interesting slide here looking at low birth weight. Moms who themselves born low birth weight in blue. We see that for this group of peeps, preterm birth rates don't come down with upward mobility. Moms who are born with a normal birth weight, we see preterm birth rates do come down. But why is it that those who are born small, preterm birth rates do not decline? So we looked at three things: low upward mobility, modest upward mobility, and high upward mobility. We looked among those who are non-low birth weight. For all those students and public health peeps, you get these adjusted relative risk pretty easily: 0.8, 0.8, 0.6, statistical significance, suggesting that upward mobility is associated with a decreased risk of having a preterm infant. But the take-home point is really the bottom line, which is the former low birth weight moms who are of optimal age. We see the upward mobility, those numbers essentially equal to unity, meaning there is no difference. You do not gain a benefit from upward mobility if you were born small. Why is that? Fetal programming. There's a lot going on now looking at fetal programming with respect to adult outcome, with respect to chronic diseases of adulthood. There's also stuff going on now looking at epigenetic type phenomena with respect to reproductive health. Fetal programming acts at the level of DNA in a phenomenon called epigenetics. Researchers have looked at low birth weight, kind of used it as a proxy as aberrant fetal programming. And the kind of hypothesis is that aspects of mother's social environment may subject her to influences during fetal life that results in her slowed growth, but also programs her to have her preterm infant as an adult some 15, 20, 30, 40 years later. And we think that's what we're seeing here. But first, let's see if there's an association between birth weight and birth outcome. So we looked at moms who were born small, less than 2,500 grams, compared to moms who are not born small. And we see that for whites, moms who were born small in blue had about a twofold greater risk of having a low birth weight infant themselves. Very similar phenomena, if not the exact same phenomena, happen among African Americans. This slide takes race out of the equation because we'll just look at African Americans. We'll take prenatal care out of the equation because we'll just look at those who receive adequate prenatal care. Look at maternal education, just like you've seen a lot now. Education makes things better no matter what. But interesting, among those who are college graduated, those moms who were low birth weight themselves had a 2 to 3-fold greater risk of having a low birth weight infant themselves compared to their peers who are not low birth weight. Again, supporting an epigenetic phenomena. There are two components to low birth weight we've alluded to, being growth retarded and also being born preterm. We see that this slide looks at SGA rates, and we see very similar bar graphs that we saw before for low birth weight. Namely, for whites, about 1.8-fold greater risk of having a low birth weight infant, of having a growth retarded infant for moms with low birth weight compared to non-low birth weight, 1.6-fold for African Americans. Looking at preterm birth, the risk isn't as strong for whites, 1.6 among African Americans. But again, it gives us some idea that maternal birth weight is very important. We hypothesized, and this is good for the students in the audience, sometimes you do a study and things don't work out like you should. We thought that moms who are born small, there would be an increased risk of having weathering, that the weathering really starts in utero, and therefore your increased risk of having a small infant, preterm infant, blah, blah, blah. We found no evidence of weathering. We see that among African American former low birth weight moms, infant low birth weight rates hovered around 19, 18, 20%. We did see a weathering pattern among moms who are non-low birth weight. I'm not sure how to account for it, but it's the data. Let's change gears just a little bit and talk about personally mediated racism. Different assumptions about one's abilities, motives, and intents by others, by race. Prejudice and discrimination, we know well. Examples, police brutality, physician disrespect, shop cover vigilance, waiter indifference, teacher devaluation. Back to our story. So now we got those pots, and somebody was in the back. In Chicago, there was an alley, and the guy who was driving the garbage truck didn't like the pink flowers, so he picked up the pink flowers and just threw them down. So that was intentional. Unfortunately, unintentional also occurs because a lot of people walked back and felt bad for the pink flowers, so they actually picked the pink flowers back up, but they put them back into the bad soil. So this can be acts of commission or omission. It really, unfortunately, and this is kind of where personal mediated racism kind of butts heads with institutional racism, because it maintains structural barriers, namely the different pots. Unfortunately, it tends to be condoned by societal norms because we don't care that much about the pink flowers to begin with. We really care about the red flowers. So we thought, well, let's do something that I don't like doing, but at some point you actually have to do it yourself, and this is more for the students. You got to come up with something. You got to collect your own data because using other data sometimes doesn't have those questions, and there's no racism question on anyone's data set that I've seen. So we asked the question, to what extent are African American women's lifetime exposure to perceived racial discrimination a risk factor for preterm low birth weight infants? So we did a retrospective study. We asked women who had a preterm infant their experience with racial discrimination. We asked the exact same question to a group of women who had normal birth weight infants. If you have a bad outcome, sometimes you're more likely to remember things than if you had a good outcome. So we had another control group of women who were admitted to their infants were admitted to our neonatal intensive care unit with some structural problem. They were born at term. Congenital heart disease, bad head, bad gut, something that is still equally traumatic with respect to life expectancy. So we had two groups, preterm low birth weight and term non-low birth weight. And we asked racial discrimination in 5 domains: finding work, at school, in the public world, and the medical arena. Interesting, the groups was no difference in the receipt of medical care. They did not experience racial discrimination. But we did find that preterm low birth weight, moms of preterm low birth weight infants more likely to experience racial discrimination finding work, and at school. This looks at lifetime exposure to racial discrimination in one or more domains. We see an odds ratio of 1.9. There is a difference. We looked at 3 or more. Odds ratio is a little bit stronger at 2.7, possibly suggesting a dose response. We control for the things that we can control for, and we still found this association persisted. Interesting, the whole concept of stress. At the same time these studies were going on, there's a study published in Quebec which showed that women who were employed in positions characterized by high levels of job strain, namely high demand, low control, I want my hamburger now, experienced twice the risk of preterm birth than those who did not experience those. Someone repeated that study in Connecticut and found something very similar. And they hypothesized that preterm birth was significantly associated with jobs that allowed little control for the employee. So we looked at our data, and we had probably 2/3 of the women worked during pregnancy, and they worked as cashiers, clerks, and teachers. And we asked them if they experienced racial discrimination. We asked them additional 15 questions. This is 3 of them. You'll watch more closely than others because of your race. Whites often assume that you work in a lower class job than you do and treat you as such. You are treated with less dignity and less respect than you would be if you were a white, odds ratio 2.0. So each of these things, women who delivered a preterm, low birth weight infant more likely to experience this compared to women who delivered a term, non-low birth weight infant. And women experience this on a chronic, regular basis. And we found that women who experience 1 or more, again, preterm, very low birth weight moms who have preterm, very low birth weights, more likely to experience 1 or more, even 3 or more. Once we got to 7 or more, we lost statistical significance, but the association still seemed to be there. So it seemed like stress at work is bad. Stress in the context of racism is also bad. Bad defined as preterm delivery. At the time our study was going on, a group in Boston was doing a similar study looking at racial discrimination among a sample of women in Boston. They also looked at white women, so they actually could look at the racial disparity. And they found about 40% of African American women experienced racial discrimination in 3 or more domains, and about 5% of white women did. The sample was relatively small, but still, they had whites that actually compare, looking at how one group compares to the next. And in this sample, they found that the unadjusted odds ratio, African American women had about a 4-fold greater odds of having a low birth weight infant. When they control for racism, that odds or risk decreased in half. They control for some things that they measured directly, namely socioeconomic status, depression, alcohol, and tobacco use, and they found that the odds ratio really didn't change. Since that time, there have probably been 6 studies looking at racism and pregnancy outcome, and I think we collectively now can say that exposure to interpersonal racism is a risk factor for poor outcome. Another study we looked at how African-born women had an improved outcome compared to U.S.-born women. This study was just kind of a survey, and they surveyed 185 U.S.-born women and about 114 foreign black women who were enrolled in a prospective prenatal care program in Boston. And they found that U.S.-born women are more likely to report racial discrimination compared to foreign-born black women. They didn't go the next step, at least I haven't seen it published, to seeing if this is indeed associated with pregnancy outcome. But it gives us an idea that maybe what's driving the difference between U.S.-born women and foreign-born women is that U.S.-born women are experiencing more racial discrimination, or maybe they're just perceiving it more. So back to our story. Somebody picked up the flower, the pink, put them back in, but when it comes to get pollinated, the pink flowers, namely internalized racism, they start to believe that they shouldn't be pollinated because they don't feel that they merit continuing on. And this really reflects systems of privilege, namely that they have not been exposed to the good soil and the sun. Again, reflects societal values because society tends to prefer the red flowers anyway. The bad thing for this is it really erodes the sense of self-value. And more than that, it also collectively undermines collective action because the pink flowers are so desperate sometimes to try to be red that they really haven't come together to try to form pink solutions. So let's see what we can do in terms of something academic to look at something that's internalized. So we did a study looking at women who experienced racial discrimination in a public setting, using the same format as we did before, but with a different cohort of women. And we asked, again, probably 20 different questions, and here's 2 of them. When I go shopping, often followed by a security guard or watched by others, or watched by clerks. I hear comments from whites expressing surprise at my and other minority individuals' intelligence or industriousness. So we looked at it, basically you were exposed if this occurred a few times a year to nearly every day. We define as unexposed if it occurred never or if it only occurred once a year. But more important than that, if you experience these things, we want to get at how does this make you feel? Are you angry? Are you depressed? Are you strengthened? And interesting, the association between preterm birth and experience of racial discrimination in a public setting was only present among women who were depressed. This slide looks at depression in the past year and also depression across your life. Further work needs to be done to get at this. So we spent a lot of time here, all the time, talking maternal child health and the concept of moms, which are very important. But us dudes, we got to have a part in this too. And we really don't see much about dads when it comes to maternal child health. And we know a lot about dads when it comes to a risk factor we know very well, namely marital status. And unfortunately, 70% of African American births occur to unmarried women. Every study that's been done since forever has found that unmarried status is a risk factor for low birth weight. But really, we haven't gone much past marital status. So we thought, well, let's look at the role of dads just a little bit. And this is still preliminary data that we presented at the public health meeting a couple of months ago that's still unpublished. But our question was, to what extent is father's lifelong socioeconomic position associated with low birth weight rates among African American women? And we looked at father's lifelong socioeconomic position, and we see that this looks at low birth weight rates among dads who had an early life, low socioeconomic position, and we found that those rates were about 10%, adulthood low, a little higher than that, lifelong low, about 10%. So they hover between 10, 11, 12%. But for those who had a lifelong high socioeconomic position, even though there were only 356 of them, their low birth rate was essentially half of that. So suggesting that there's something that dad's contributing to the plate here that's related to his socioeconomic position. So we thought, well, this, again, maternal education is a big player here. Let's look among women who, across the education spectrum. We see that from dads who had a lifelong low in blue, lifelong high in red. In each case, those who had a lifelong low had higher rates of low birth weight compared to fathers who had a lifelong high. And it occurred in each education strata, whether less than 12, or some college education, suggesting that there is an independent association of paternal socioeconomic position and low birth weight. Look among marital status. You really think if you're going to have the more bang for your buck, it's going to be among married moms. And we see indeed that marital status is associated with the decreased risk of low birth weight, which we knew. But we see among unmarried moms, low socioeconomic position was still a risk factor. Among married moms, we see that the gap's even wider, but we start to see some evidence of a low birth weight rate, which is very low among those of high socioeconomic position. That could be a little bit of a fake out because our numbers are really small. We only had about 350 dads who met that criteria. But it gives us some idea, some suggestion that fathers do matter with respect to pregnancy outcome. So we matter because we can reduce stress. On the same token, we also create a lot of stress. And I try to tell my kids that some stress is actually good for you, even though they don't always believe that. But as a species, we are really equipped to handle certain stress, particularly stress when it comes to acute stress is, I think, what we do well as a species. And that's probably best thing that if a fire alarm were to go off now and we would actually smell smoke, our heart rate would go up, blood pressure would go up, our ability to run would be a little bit faster than what it was an hour ago. And we get outside and find out it was just, somebody threw a cigarette butt into a paper bag thing, and we come back in here, our heart rate comes back down, blood pressure comes back down, we're back to being slow again. And that's what the human body does. Allostasis. We kind of maintain stability through change, and that's kind of good. We really handle acute stress well. The problem is, and this has been done with mostly in laboratory animals, but some in humans also, if you really repeat stress, guess what happens when you're exposed to an acute stressor? You do have the initial response, heart rate goes up, blood pressure goes up, due to a whole bunch of hormones which are secreted. Take the stressor away, things do not come back down. And maybe that's what's going on here with preterm labor and this whole problem in terms of physiology, in terms of how this is going to work, in terms of African Americans and stress. So maybe this is all stress-driven to a big degree, that if you're stressed out, you have an acute stressor, you can't remove that, you remove the stressor, but you still have the residual effect. And one of the reality is that we know a lot about preterm birth, maybe. We don't know a lot about term birth. We don't know what causes term delivery. That's a problem. We know that increased stress can increase your risk of preterm labor. Yep. We know that increases your risk of infection. It does. But studies have shown that it's not the silver bullet. But maybe it's not so much the infection, but maybe it's the body's over-response to the infection that causes preterm birth. So there are two things going on. One is what happens when you're a fetus, if you're programmed to have a preterm infant. Two is what happens when you're adult and how you handle stress then. And somewhere between those two things, we think that it tips African American women over. So this is a slide, kind of a summary, looking at preterm birth being the tip of the iceberg. We talked some about weathering, bad housing, unemployment, bad neighborhoods. Clearly poverty is important. We hinted at the importance of class. We hinted about job strain. We hinted about poor working conditions. We really didn't talk about the importance of nutrition. We really didn't talk about the importance of environmental toxins, which are somewhat related to where you live. But those are also very important things which merit important consideration. From a public health perspective, what it means is that taking care of women during the 9 months of pregnancy is exceptionally important, but it's a lot to say that we're going to expect 9 months of prenatal care to reverse a lifetime of what's been going on. We really have to look broader than that. We have to look at a life course perspective when it comes to interventions also. Michael Liu and his colleagues came out with this 12-point plan when he was a practicing obstetrician in California. And these 12 points, I think, are rather important. The first 4 points move us beyond prenatal care and really start looking at taking care of women between pregnancies and from the time that they're little girls. The next 4 move us beyond looking at individual risk factors, which we do very well in epidemiology, and looking at the importance of neighborhood factors and household factors. The last 4, closing the education gap, reducing poverty among African Americans, supporting working moms, undoing racism, those things are tough. But those things are what needs to be done, because everything else has really been looked at from a medical model. What we really need to do is shift the paradigm to not a medical model, but really start looking at the social determinants, which really are the root cause of this problem. It's overwhelming, but a lot of things what we do in life are overwhelming. This was a different scenario that was applied to JFK back in the day with respect to another problem, and he wrote, "All this will be accomplished will be finished in the first 100 days, nor will it be finished in the first 1,000 days, not in the life of your administration, not even perhaps in our lifetime on this planet, but let us begin." And one of my favorite poems from Langston Hughes, "Let America be America again. Let it be the dream it used to be. Oh, let America be America again, the land that never has been yet, and yet must be, the land where every woman is free." Thank you very much for your attention.